Well, good morning and thank you for attending this steering group meeting of Healthwatch Coventry, and a welcome to everybody watching us on YouTube, members of the public, because this is a public meeting and you're very welcome to be with us today. Members of the steering group will be expressing their point of view, and we have a presentation coming our way on the merging, I should say, clinical commissioning group for Coventry, Warwickshire and the surrounding area. So welcome to our meeting. And we have news of a member who is stepping down. Ruth, please.
Hi, yes. So Ed Hodson, who has been a really good participant in the steering group over the years, he's currently a co-opted member representing CAB. So he's been in touch to say that his role is changing at CAB, and so he's stepping down from his role on the steering group at the moment. So I'll get in touch with CAB and see what other linkages we can put in place. But he feels that he's not able to make enough contribution to this group at the moment.
Okay, thank you.
Otherwise, today we have apologies for the meeting from Sue Ogle as well.
Good, thank you. Any declaration of interests from any members present? No, thank you. Minutes of the last meeting have been circulated. If everybody is happy that they are accurate, if not, please say. And are there any matters arising from the last minutes that are not included on today's agenda? Anybody wants to raise now? No.
I think everything is covered within the agenda or has been completed.
Thank you. In which case we move to our guests and welcome Rose Ewins, and more particularly, with no disrespect to Rose, Phil Johns, who is the accountable officer for the merging clinical commissioning group, or groups, whichever is most appropriate. And Phil is going to take us through their plans for the merged CCG, how it's all going to come together, how it is all coming together. You can see from the smile on his face, it's all going superbly well. The integrated care partnership, which we're hearing so much about, and how that affects Coventry and Coventry Place, and the relationship with Healthwatch Coventry, we want to hear a lot about as well. Phil, if you can take us through that, and the engagement, the involvement you're going to have with patients and the public. So Phil, we're in your hands for the next few minutes.
Okay, I'll try and take them in order, Stuart, if that's okay. So we'll start just in terms of where we are at with the merger of the CCGs. So yes, I hope that is now all going to plan as we merge in 2 days' time. But we're not aware now of anything that is outstanding for us to do there in a technical sense. We're compliant with the requirements set out for us by NHS England, and we have a plan around how we bring together various parts of our functions. It's probably worth colleagues on the call knowing what we have done because of the ongoing response to the pandemic. In terms of our own staff, they all 2P into the new organisation on the 1st of April, and then we will start commencing around the management of change process. But it wasn't fair back in January when we believe we'd be looking to move all of our staff out to help partner NHS organisations, to also expect them to be running through a process around applying for new roles or slotting and matching to new roles, or whichever it may have been, depending on individual circumstance. So that process will start at some point in April, once I have done the work around the executive team. And actually the process has been run very well by my colleagues. I can't take any credit, only having been here 4 months. The process has been relatively smooth and has gone as well as can be expected, apart from a small couple of hiccups that we think we've now resolved. And the first meeting of the new governing body in public will be Thursday morning for anyone interested in attending that. And we will continue with public governing bodies as the previous CCGs had, in terms of being open to scrutiny and at least our decision-making process and thinking being in public, even if not the opportunity to challenge there, remembering they are meetings held in public rather than public meetings. What this does do is put us on a very firm footing as we head towards the next NHS reorganisation and the move to statutory footing of integrated care systems on the 1st of April next year. That difficulty that presents for me personally and for the wider CCG is to be careful that all we don't do for a year is to manage 2 sets of transitions. So if all I do for 12 months is manage staff into one organisation out into another, we won't be able to do anything in terms of actually impacting on the care that our patients receive. And one of the first tasks for the new governing body is just to be clear about what it is we're looking to achieve for the next 12 months or so. The move to integrated care system, I think, though, is the right thing to do. This is about being much clearer about how health and care organisations work in partnership. You'll all have seen some of the cracks and the fall downs and the handovers between care that exists within the NHS and exists between health and social care. Clearly, they won't all be fixed on the 1st of April next year, but actually a much closer collaboration, bringing local authorities in as statutory partners into the health and care partnership. It does mean there's a better set of voices, wider set of voices about how we're approaching things, and helps deepen the partnership that already exists between health and care going forwards. So the aim of ICS is, of course, is to start looking at health and care and wider determinants of care, looking how we can impact on keeping people well rather than dealing with them when they're sick going forwards. All of this takes a long time, so I can't make a great promise that things get fixed next year, but the direction of travel is absolutely right and tries to unpick some of the problems that the previous set of reforms might have created in the past. Within that, we have to be careful we don't lose the voice of general practice. So our GP colleagues have been very influential in clinical commissioning groups. It's important that we keep their voice as the people who actually provide the bulk of our care. People's most common day-to-day interaction with health is with their GP. So we need to be careful as we form an ICS that we've maintained that voice of general practice going forwards, and it isn't lost when set up against or with the voice of the big statutory NHS providers, the hospitals in the system, and indeed local authority colleagues. But again, an integrated care system is what it says on the tin. Effectively, the GP voice will hopefully remain key within that as well. My tasks over next year is to be clear about how we'll make sure general practice is involved and all of supporting infrastructure that comes with that. So those of you, I don't know the membership, I'm afraid, I probably should ask for a bit of a round of introductions, but some of you may be on PPGs and the like as well. We need to make sure that there's a voice from PPG through to general practice through to the ICS within there as well. In terms of how this system sees it working as part of Coventry and Warwickshire, we propose 4 places. For this particular group. Coventry is clearly going to be a place within that. What we think we will end up with, I'm conscious now I'm going to blind you with acronyms, so it wasn't my intention really, but every integrated care system will consist of a number of integrated care partnerships. That will be a statutory NHS provider basically holding the collection of contracts that the CCG currently holds and trying to arrange and order care in a more sensible way. And the reason we feel that makes sense is, of course, that it's professionals working in those organisations and their more extensive links out to patients that can see the various handoffs better than somebody like me sitting in a commissioning only organisation and trying to almost tell people how to fix it, commission the right pathway. Well, it's a good idea in principle. But actually for it to work, it needs to relate to the people on the ground delivering care, and hence the integrated care partnership construct would mean that Coventry and Warwickshire Partnership Trust, general practice colleagues, University Hospitals Coventry and Warwickshire would collectively decide on what the right thing is to do, as opposed to a CCG saying, do this please, and then trying to manage the handoffs from 3 separate contracts. That doesn't really work very well, hasn't really worked over the last few years. So you'll have an ICS integrated care system partnership over Coventry and Warwickshire, looking probably at things like the top end, the specialised services care that we deliver on behalf of our patients, but actually has to happen at UHCW as our big tertiary provider of care, or in some cases in Birmingham, where the care actually is more specialised again, that UHCW isn't currently able to provide. And then in each place, an integrated care partnership working on the care that is delivered at a Coventry level, so general practice, community services, some parts of mental health services, and obviously the linking with local authority and social care. And then even more micro level, you have the primary care networks, which is how the GPs, as you'll know, are currently working together to try and order care around their population, move away from just focusing on their practice, focus on the population they have. And underpinning all of that, we approach around population health management and starting to look at the data in a slightly different way. What can we do to improve people's experience of care? What can we do to make sure that we're using all the resources that we have to really sort of double down on those populations that are struggling to access care at the moment, which is all a bit nirvana for the future, but is an explanation really of a direction of travel. So we need to move on to look at difficult to treat populations, and particularly how organisations, rather than competing as they may have done in the past, now shift that focus to what I think all patients would say is the right collaboration around delivery of care, and trying to put their organisational boundaries to one side. That's the absolute task of an integrated care system going forwards. I'll probably pause there because I'm aware I've probably said quite a lot, and I'll come back to the priorities and how we work with Healthwatch and engage with patients, and just see if there's any questions. I'm not sure I've made that as clear as I intended.
Thank you. And if you could, if you do have questions for Phil, if you could introduce yourselves as you go along so that he's more aware of who you are, and just a member of the steering group. Anybody want to comment as we stand at the moment? Any questions for Phil as we are at this point? Have you stunned them all into silence, I wonder?
Got Christine, I think.
Oh, yes. Thank you, Phil. Yes, Christine. Sorry, you're muted, Christine. You're muted.
I am. It's probably a good thing. Sorry, thank you, Phil. I'm Chris McNaught. I'm the Chief Exec of FWT. We're a women's centre who works citywide in Coventry. Very quick question, Phil. I might have missed it. You said there are 4 places across Coventry and Warwickshire. You said Coventry. Can you tell us what the other 3 places are, please?
Yes, Warwickshire North, Rugby, and South Warwickshire. You're now mute, Stuart.
More or less the structure as was, is it not?
Yeah, we're trying to keep the existing place-based links in as best we can in existence. It's really the removal of the commissioning tier, my tier, that we're trying to take out.
Okay, thank you. Anything more at this point, or are you keen to hear more from Phil about relationship with Healthwatch?
Stephen's got his hand up, Stuart.
Yes, it's right on. The screen keeps moving around, and you were down at the bottom right of my screen a moment ago, Stephen. You're at top left.
Okay, no worries, no worries. Hi Phil, obviously we met yesterday, and I do want to sort of pick up on some of the stuff we were saying yesterday in terms of not only Healthwatch, but in terms of voluntary and community organisations. Where do they fit into the ICS partnerships? Do you see them sitting in ICS partnerships, or in all of the different levels? Where would you see? And it probably, some of it, obviously, I'm here for Healthwatch, so you'll probably pick some of that up when you talk about Healthwatch later. But, for those in the room, not everybody's sort of, VCSE, or, I think it's interesting to hear the full spectrum of where you see the VCSE sitting in all of this.
So I'll reply a little bit of a discussion also we had yesterday for wider colleagues as well. I think what we concluded actually was that we need to get more advice from voluntary sector colleagues about where they would best input into the wider system, and avoid the danger to add a perceived voice of the voluntary sector to every group that we have, and expect them to have to talk on behalf of all their colleagues. So I see involvement of the voluntary sector at the integrated care system level, but most pertinently into the local place-based working, where I think that real benefit of the the reach and expertise that voluntary sector colleagues can bring that statutory health organisations certainly don't have can be felt, but that we need to find a way to get the right organisations into the right rooms, rather than probably, as we have in the past, working through almost umbrella organisations and expecting them to have to represent all parts of the voluntary sector. But certainly, in terms of what I set out in reaching some of the difficult, bad word I can't think, but hard to reach groups in our population for various reasons, voluntary sector going to be absolutely key in that, because we don't have those kind of relationships. And there's all sorts of reasons that people choose not to access care, or feel they're unable to, or don't know how to access care. And I think that there's an absolute need for the voluntary sector there. And again, as we discussed around yesterday, moving people on from seeing voluntary sector organisations sometimes as competitors in terms of delivering care. The method and type of delivery is different in many cases. So certainly, just be on a call with some Warwickshire North colleagues, that using the voluntary sector as an alternative to statutory health is more where we need to start thinking, as opposed to somebody who's providing a similar set of services alongside health. That's where we need to change our thinking a little bit more. And I've done it in the past, particularly around mental health and improving access to psychological therapy stuff. We work with a third sector collaborative there to start providing some of that care, as opposed to statutory health organisations, which just meant they were more successful in reaching out to populations we probably have missed. And let's try and bring some of that approach into both the system and place here. Not sure Sonia or Steve, obviously both were on the call yesterday. I think that's probably a fair recap of where we got to.
Yeah, absolutely. I think it's just good for people in the room to understand that these conversations, again, outside, happening outside of these meetings as well. So.
Just to say, obviously, I have an awareness of those conversations around the relationship with the voluntary and community sector. As a Healthwatch, part of our membership of this group are from voluntary and community sector organisations, and that's in the recognition really of the reach of such groups to different people in our organisation. So it's distinct from the role that different voluntary or community groups might play in delivery as such. So that's the kind of dividing line, if that's the right phrase. So,
Thank
Apollo's got his hand up.
Yes, Apollo, do introduce yourself and put your question. You're muted. You're muted, Apollo.
Thank you. Good morning, Phil. I'm Apollo Economides, member of the steering group. Could I ask you how you see the local needs of the population of the previous CCGs being met in the new merged structure?
So I don't lose any of my responsibilities or accountabilities to local populations. So actually the reason for the merger in many ways was to make sure we had one consistent approach to commissioning across the system, which we hope would realise some benefits in and of itself. But in terms of the needs of the residents of Coventry, you shouldn't see a difference in terms of the services you can currently access. And I hope as we move more to that integrated care partnership framework I've described partially, you hopefully see a smoother experience of healthcare between the various parts of health that you'll access, as opposed to the more fragmented, I suspect, experience you've got now. So again, it's probably half an answer, but the requirements of the people of Coventry have to be at least as important as the requirements of the people of Warwickshire in a Coventry and Warwickshire CCG. So you shouldn't see any diminution of Coventry as a place just because you've got a bigger organisation.
Does that answer your question, Apollo?
I think so. I reserve the right to come back afterwards. Thank you.
Thank you. Can I just ask you, Phil, to expand if you can? I mean, I know it's possibly early days to do this, on how you see this notion that's been made so much of, particularly by the politicians, of collaboration rather than competition. How is that going to unfold, particularly in this part of the world, in Coventry?
So one of the things we'll have seen in the past here and elsewhere is a way that part of it's driven by how we used to reimburse providers for their healthcare, and of course my organisation is the one that funds other local providers, and we were doing that in a way that meant I would put some money with University Hospitals Coventry and Warwickshire. We'd put some different money with Coventry and Warwickshire Partnership Trust, and we'd probably put some different money with General Practice, all of which in theory we'd align, but it never quite got there, because actually rather than commissioning and sort of an end-to-end pathway of care, I was basically buying 3 different components of it from 3 different organisations, all of whom would then take their own approach to delivering that care. And what we're trying to get to is actually a place where I will commission from the partnership that care, and they will agree between themselves the best way to use that resource, as opposed to 3 different approaches. That's the theory of integrated care partnerships. It's my job to make that happen in reality. And also we'll move away, legislation notwithstanding, from the procurement approach that we always had before. So we were always encouraged to go to market under the 2012 Act for many of our services. My hope is, and certainly the intent of the legislation that's being consulted on, is that we have more legal authority, I guess, to be able to directly award work to large organisations that already exist, rather than always have to go through a competitive process.
So is it fair to say then that as well as hopefully providing more effective care, it's also going to be more efficient use of public funds, essentially?
Yeah, it should take out some of the transactional costs that we've built in by nature of having to go through a procurement process as well, which hopefully frees up more funds for the local system.
Right, thank you. Let me see. David, beg your pardon. David, yes, you want to say it.
Thank you. David Spurgeon, I think I've been a member of Healthwatch for a long time now, not quite lifelong. This might be a cynical question, Phil, but I don't think it's political, because we're talking about the same Conservative government all the way through. As a complete amateur in this, you've used the word the integrated care system is going to be a much better organisation. And not using your exact words, but you're implying this is a better way forward. But Andrew Lansley and David Cameron, when they set up the current system, said that was the better way forward. So could you explain to us novices on this, at least I'm a novice, how this is better and why it won't change again in a few years' time? And one more thing, how can they be pushing ahead with an integrated care system when we still have no idea what the government is going to put forward in their white paper for social care?
Okay, thank you.
David's been doing it for quite a while, but the nature of the question, Phil, it's well thought through.
So I guess the difference between 2012 and now is there's been a discussion with the Health Service, the Local Government Association and the like about how we think things should be put together. And 2012 wasn't really, to the best of my knowledge, in the role I was in at the time, a discussion with health and local government partners about how we thought things should be put together. It came from I don't know where it came from in terms of the gestation of the idea. Also, of course, came from belief that we'd be able to manage health as a market, and within that, therefore, that we will go down a procurement and contracting route to trying to order and to deliver care. And I'm not sure. It didn't work. I'm not going to comment on whether it was the right thing or not, and whether a market-based approach is right or wrong. But the point of this set of reforms is to try and reintegrate both how we plan care. So at the moment, somebody else, NHS England, plan our specialised services, even though we provide quite a lot of those out of Coventry and Warwickshire. And I work on planning the more day-to-day care that you receive. And try and put that back together. And in the same way, dentistry, pharmacy, optometry, commissioned by NHS England, but all of you will experience that locally, and I don't get any say in how those services are commissioned. So that will all come back into one unified approach over time as part of an integrated care system. So broadly, I'll be commissioning all health that is received by our population, which means you can look at the whole pathway. So I can look at doing things that probably would hopefully reduce burden of kidney disease, as an example, and then hopefully reduce our need for high-end care and have the benefit of doing it. Not to say we don't do it at the moment, but the resource benefit of doing it sits in a different organisation, which doesn't make any sense. And in terms of putting those integrated care partnerships together, effectively those organisations get to manage the whole supply chain, if I was putting it into business terms. So where people go through the whole of their experience of care in a way that doesn't happen at the moment. And in terms of my previous answer to Stuart's question, we hope to take out some of the transaction costs that come with going through a procurement process and a contracting process for almost all of the contracts that we award. I can't say whether there'll be another change in 5 years' time or 10 years' time or not. All I know is there's a cycle, and that we tend to go through sets of reorganisation of certainly the commissioning side or planning side of the NHS every so often. So I hope we get a level of stability. CCGs were around for about 9 years by the time we get to the end of the period, and you need some time as you set off as a new organisation to try and make a difference. So I hope we're not heading for another set of reforms, post another election. But obviously, I don't have any control over that, and I guess will depend potentially on the colour of the government, all those kind of things that are to come. Social care is you're absolutely right. We desperately hope that the forthcoming paper on social care gives some clarity about where we're going with that. Even if it doesn't, even if things are as they are, the intent to work more closely with local authority colleagues is still right. So I don't think we should stop trying to work more closely with local authority colleagues whilst we wait to see what the government are saying about social care, because as far as I can tell, it still exists. There'll still be a requirement for social care where there's a different funding mechanism, where there's a different entitlement, where there's a different answer around it coming forward. I don't know, and the national policy rarely gives an answer. It will give us a direction, but the answer sits still with local organisations in terms of how we deliver it. So I don't think it precludes starting to work together more closely or continuing to work together more closely, but it might just change the nature of that discussion going forwards. Do I think all the answers will come out of a white paper? No, but then they never do that. That's the nature of them, is to set a direction and a policy going forwards, and we'll have to adapt to how we work with that. I don't know what's going to be in there, so I can't say much more than that at this point, David. But I will say I do think this is absolutely the right way forwards. Whether personally I've done a few things differently is academic. Bringing health and care closer together has to be the right thing. Bringing NHS providers back together has to be the right thing, and letting professionals and patients who experience care having a bit more say now that care is delivered between organisations has to be the right thing to do as well. And the set of reforms we worked to for the last eight or 9 years, whether that was how they were intended or not, has proved to get in the way as opposed to make that easier.
Thank you, Phil. Well, personally, I think that was quite a comprehensive and convincing answer. So thank you.
Thank you, David.
I know Stephen's got his hand up, but I'm just wondering whether we should hear the other bits that you were going to talk about, Phil, in terms of the priorities and the challenges, and also Healthwatch, and you've kind of alluded to patients, the public having a voice, but I guess at the moment we're not quite clear how that's going to work.
I just was it a very quick question, Stephen, that you wanted to put, or?
All right, we can pick it up later if we've got time, but it may come up in what we're hearing now.
Okay, Phil, over to you again.
Okay, well, so I mean, obviously, I have met with Stuart and Ruth and discussed our ongoing commitment to work with Healthwatch. We have many ways of getting, I guess, a patient voice but Healthwatch is one of the ones that we can use more easily, more readily in terms of breadth of access, I guess, to patients going forwards. And similarly with Healthwatch Warwickshire, obviously recognising that they're set up as different organisations. I'm going to let Rose come in a little bit and talk in a bit more detail about what we're going to do, in part to give my voice a brief rest. I do these calls all day in terms of talking at computers at the moment, it seems. But certainly after Rose has spoken, happy to take any questions about further detail. I would say that Healthwatch won't be our only route into patient groups. It'll be part of how we reach out to our population, which I'm sure you probably expect me to say as well. But just to be absolutely clear, we have a number of ways we'll reach out, all of which we'll try and use. But obviously, Healthwatch is a key component of that. Rose, do you just want to add a bit more to that?
Yeah, and I think this is part of the conversation. I know, obviously, I've been updating people as we go, and Ruth and I have been working quite closely on our engagement strategy going forward now, because we hope to bring that to you end of last year, beginning of this, but obviously with COVID second surge, we took the decision to put that on hold. But I think it's partly just reiterating that commitment that we're really, really keen. We've said throughout that we see Healthwatch as an absolutely vital part of what we do. You reach a lot of the communities that we absolutely can't, and also their wider representation from the steering group into other voluntary sector and community as well. I think we are very committed to taking that. So I think for me, the next steps are going to be looking back to that communications and engagement strategy that was developed, bringing that to you. I think it's a work in progress. It will always be a work in progress. We'll never have a definitive strategy, and I want for your support to shape that and how we look at that. For me, a lot of it is about making sure that we're getting the information flow. And as Phil mentioned earlier, it's going right down to the PPGs and the groups and GPs, and how are we getting information, even at an ICS level across Coventry and Warwickshire. It still matters what's going on, for example, FOSL. And what their PPG is saying, and we still need to have those links. So I think part of our commitment to that is working with Healthwatch to make sure that the information that you get, and I think it's been working really well with Ruth on things like vaccination, where you're hearing information about particular vaccination centres, problems with park, all of that, making sure that we really have those routes and we can hear that information through. And also when it's working well, because it was great to hear that actually you've been back to the centre, and the particular one that we were talking about, and it's improved. So I think that's one of the biggest commitments. I think there is still that ongoing discussion. I know Ruth's in discussion with Andrew Harkness on a regular basis. It's about how and where Healthwatch best fits in. I think it has a role at every point, and we discussed this as well in terms of at ICS level, but really at place and that delivery and how that fits in. So I know that's part of the ongoing conversation as well. There isn't any definites yet. Obviously, we're still moving things around and working out what works. But I think the most important thing is that there's the value that we place on Healthwatch, and the value that we've already had working together, and how we can align what we do. And one of the things I know Ruth again and I've talked about is that some of the work, making sure that the work that you do and these sort of investigations into services that you do, which are so important, work in tandem with us, so we know that they're coming, we're able to respond and actually make a difference immediately, rather than, I think, the case with some of the things that they've landed and we've not quite known how to respond or when to respond. So it's making sure that we streamline that and we fit in with your work programs, and we share our work programs back to you, so we can have that more coordinated approach. So I know you hear from me all the time, but hopefully we are working in terms of that. Just
so obviously don't disagree with any of that, but I guess what we're looking at from a Healthwatch point of view as a body that has some statutory functions and a kind of bigger picture role in terms of representing the interests of patients and the public. It's more how everything is going to be connected together, and how patients and the public voices kind of influence the culture and the planning within the system and the place, really. And we were just having a similar discussion in our pre-meet around work planning and how to go about doing that. At the moment, one of our challenges is that we kind of feel too cut off from all of the information that would actually help us to build something which could integrate a bit more into the work that is going on, into the priorities, and to actually make sure that we can bring the voices of local people to the table in the right way and at the right time. So those are some of the things that we're kind of looking to be addressed, and I think it's quite urgent, really, to make sure that is built into the structures, because it looks like there's a gap, really, and there's a lot of local determination allowed within the white paper, and we see good work going on in other areas of the country. We hear from other health watches about how things work, and I guess the different approaches that are being taken in other areas of the country, and there's a lot to learn from, really.
Happy to hear about other approaches and what they're doing. Always happy to learn from other colleagues. Some, of course, will be further ahead than we are in terms of where they've already got themselves to a position where their organisations are coterminous with their ICS that's to come and the like. I mean, I can reiterate our commitment to trying to get some of our resources down to a place level, and those, I think, will be the individuals we'd expect to be working in more detail with Coventry in this case. It's a strange world in terms of priorities at the moment. You'll all be used to in the past CCG colleagues coming on and talking about what they were trying to agree as a set of priorities with the CCG governing body and with wider colleagues, and looking to consult on that. At the moment, you'll know that most of our priorities are pretty much mandated in terms of what we're going to do. So certainly for the first half of this financial year, from Thursday, we're looking very much at restoration again of services, and that will be targeted initially at those people requiring what we term time critical surgery, people who need operations more urgently because of the nature of their condition, and also trying to fully restore, although less of a task in Coventry where we've done pretty well with it, but fully restore cancer pathways and diagnosis pathways and the like, and to deal with what we think will be the, I was going to say tsunami, it's a terrible description, but the bulge of mental health pressures that we're probably already seeing, but actually is now, with schools having gone back with the reality of people whose financial positions might be changing as furlough and the like comes to an end, starting to hit home. We are expecting to see a further increase, and there's already been an increase in demand around mental health services. But what I can do actually is say that actually I or a colleague will come back here and share with you those priorities, much as they're set nationally. They're the right things to be doing given where we find ourselves. And obviously I can commit in terms of our future planning that we'll talk to yourselves and to wider patient groups about that by very much envisage it for the next year. I'll be working to a set of priorities that are given to us, but probably worth coming to talk to those to you about those and how they might impact locally at a future meeting.
Yeah. Understood, and I think it has been an unusual year, but one of the things that has kind of come from that, really, because we are part of a broader Healthwatch network, is that there has been quite a, I guess, coming together across the Healthwatch network, and some of the work that Healthwatch England is now pulling together is starting to have a national influence as well. So that's what we would want for our local people, isn't it? That we would be part of that kind of process when priorities are being set in a top-down way, because not everything kind of works in the way that it might have been envisaged in those circumstances. And we also need to think about the nature of our local population, don't we, as well, and where that fits within priorities. And I think communication is going to be a really important area of work over this next phase of restoration as well, really, and communication and dialogue with local people.
I think one thing we hope to take in terms of learning from the vaccination programme is how we've managed to reach out to some of the communities that we failed to reach out to before, because probably, and it's a generalism, but the same people that have found it harder to access a vaccination programme are probably the same people who may not take up a flu jab or who may not take up opportunities around breast screening or other things that we do as a matter of course. A lot of the preventative work that we try and do, we'll find it's the same populations we think that will struggle to access that, and to bring the learning for how we've managed to reach out to an extent to those communities, to that wider array of services going forwards. And we can use some of the other work also we've done around individuals with learning disabilities, how we've managed to start getting some of them to take up health checks, which of course then potentially leads to onwards referral to other services where we spot things we wouldn't otherwise have identified. So really keen to work with you guys on that, and certainly to make sure we don't lose the different approach we've taken because of the absolute requirement to maximize vaccination uptake, but it really does apply to many of the other services that we offer.
I think one thing that David and I both sat in on some of the meetings that took place in the early stages of preparation for the merger, when things like structure were being examined and explained in many ways to the existing CCG membership. I think we came away, both of us, David and I, certainly with a concern, and possibly this was a function of the early stages of the planning and the point that had been reached, that there seemed to be very little involvement of the public, of patient response, patient reaction, patient input into the CCG going forward. So it's reassuring to hear from you that your intention is to embrace through Healthwatch and indeed through other sources that sort of engagement with the public.
Yeah, no, absolutely, sure. That's what I want to get us to, and certainly as we move into our next statutory incarnation, and whoever may be here, I think one thing we need to make sure as we become a Coventry and Warwickshire system is that we don't get so remote from our populations that we can't hear them, which may have been the experience of some of the predecessor bodies that have sat at that level. I think that part of the role of the integrated care system is to make sure it does capture the voice of patients that can play that back to the 4 or maybe 7, not quite how many there'll be yet, but integrated care partnerships that we commission from. Discussion we haven't had that we'll need to involve you in will actually be, is there a direct link into those integrated care partnerships, particularly given the nature of, if I've got one for Coventry, it would make sense actually you have a direct link into there rather than sort of come through an intermediary system organisation instead. And that discussion we haven't had anywhere yet, but we'll be keen to be getting onto that as that forms up.
Good, thank you. Is there anything more that you want to pass to us before we just open up any more questions as we're near the end of our time? No, any further questions then for Phil or for Rose before we thank them? Ed, yes, please.
Sorry, I joined late. So would there be any more kind of representation for Healthwatch and more strategic committees of the CCG? Just because some of the commissioning committees we attend, it kind of feels like plans are presented to the public when they're fait accompli, when they're already complete, and then consultations an afterthought. And Healthwatch already collects loads of data, especially during the period when patient satisfaction monitors has been suspended on digital health and digital access and the barriers to that. And that could be considered in quality of care and things like that. So we do produce useful information that could feed into planning.
So I think I probably just need to understand more fully what you've already got. As I've had some discussions with Ruth and Stuart about that already, because that's a good example. We are making a presumption in the NHS that digital is a strong way forwards, and to an extent we're going to have to do that because we won't have the workforce to do things as we've always done them going forwards. But I'm aware not everybody's got access to the same sets of ways into digital services, and also not all people are comfortable necessarily working that way round as well. But some parts of the population, it's bread and butter now. So I think that kind of feedback we can get, and also given it will be delivered differently, certainly from general practice, depending on which practice you happen to be at, trying to get hold of that feedback from you guys to inform things like our digital strategy, which really, of course, is our care strategy going forwards, would be really useful. Otherwise, we'll give you a one-size-fits-all answer only to find it doesn't fit. So can't give you lots of half answers, but I think I probably just need to get a better understanding with colleagues and certainly the people that will lead the integrated care partnership in Coventry about people's experience of things like digital care, which of course you guys are well placed to help us with, and it is a discussion that we've had with.
It's definitely an area that's been on our agenda for some time, and Healthwatch England produced a report which is around access to GP services last week, which went round in one of our newsletters. So there's definitely a digital strand in that feedback, really. So all over the country, local Healthwatch are hearing more from people about issues around access to GP services. So there's more work to be done, I think, in terms of understanding what will work for people digitally, locally, and how it can be adapted and made to work with our diverse population groups as well, and how some of the inequity, I guess, can be addressed.
If I can just jump in there, personal perspective, which others may or may not agree with, I just think this possibly is one of the most important issues to address right now, urgently and immediately, really, because as you said, Phil, the more I attend meetings and the more I hear what comes out of various parts of the NHS structure, this is obviously going to be the way forward, using digital means of access to all levels of NHS services. And it isn't possible for everybody to partake in that. It isn't everybody having a good experience from doing so either. And as for the GP services, as Ruth said, there is a report out. There's no question you've got a complete patchwork quilt of services being provided. Some very good, some absolutely dreadful. And I think it really does need attention. I'm not saying necessarily at your door, but it needs attention as a matter of urgency. Any further questions, David? You've got yourself off video, but I can't hear what you're saying. Have we lost your signal for the moment? Well, while David's reconnecting, Stephen, did you want to come back with your question from earlier? Have you heard what you wanted to hear?
I mean, I can, yeah, we can pick it up another time, but I suppose it is more around accountability, scrutiny, in terms of, you talked about integrated care partnerships and the sort of non-commissioning of services or the, being able to award money to the organisations you've talked about there. I suppose, it's asking the question whether there'll be some scrutiny over, what we're interested in is obviously quality. We want quality services for the public. That's what Healthwatch is, one of the key things is about, hearing about the services that people receive. But also, I'm sure you want value for money as well, and you want to make sure that you're getting the best with the money that you've got. You're getting the best quality. So will there be some accountability in that way from those organisations?
Yeah, so I think there'll still be a contractual relationship between me as the person purchasing care, and in there'll still be quality standards in terms of what we expect to receive back. I think the framing of them might change. I think it might be a little bit more about end-to-end and the outcome for the patient, rather than maybe some of the process that we look at the moment. In terms of value for money, there's a piece of work the system needs to do around where there may be waste, where there may be high cost care. At the moment, now, of course, high cost can be value, so you just got to watch the definition a little bit. But we do, yeah, no, absolutely. In terms of quality, there'll be ongoing arrangements in terms of value for money or waste to be worked through, but that will still exist. So part of a plan, I think, for an integrated care partnership will be how are we going to live within, deliver care for the resources we have available to us, but in a slightly different way. So I think we will make effectively awards based on allocations of funding that the CCG receive to the integrated care partnership, and the task for them in a sense is to deliver best care living within that envelope, whereas in the past we've basically paid for episodes of care, and we'll be trying to move away from that. So the arrangements to be worked through, and I am going to be subject, I suspect, to a plethora of guidance that will be coming down from colleagues in NHS England, but in intent, with best intent to make sure that we don't let things slip through the cracks and the gaps of handing over to a new system, to make sure that above all that care remains safe whilst we work our way through. So I might make the odd comment about numbers of checklists and things I'll be expected to fill in, but obviously there is a purpose for the requirements I'll have to go through. And indeed, because we've just merged, much of the learning about our handover of process between the sort of predecessor CCGs and my new one, Thursday, will also stand us in a good stead as we move on into an integrated care system, because certainly any quality concerns that we have over the next year, if not addressed by them, will need to carry forwards into the new organisation, and anything you guys have raised with us that we've agreed to work on will need to carry forwards into the new organisation as well.
Stephen, thank you for your question. We've got time for one final one. We are over time actually, but David, is it a quick question?
Well, it's a follow-up to Ed's point about digital. A survey's been carried out, Phil, a large survey amongst GPs, which apparently has come back with the result that the vast majority of GPs want to resume practice-based appointments. They realize that digital works very, very well for many people. They also are very conscious of the fact that it doesn't work very well. Quick anecdotal, I don't normally do it. My wife phoned this morning to the practice. She was told appointments are only by telephone. That was a recorded message. When she got the receptionist said, yes, we will arrange appointments. It can't be today, it'll have to be tomorrow. I can't tell you when it will be tomorrow. My wife has actually got a second vaccination tomorrow. She said, well, if you can't tell me, I could go on with that story, and it's all right, very anecdotal. But I think quite a lot of people, and not just older people, would be immediately put off if the very first thing they heard on a recorded message was all appointments are now being conducted by telephone or digitally. And I would just urge you, if it is the GP's wish in this city and Warwickshire to resume live actual appointments in surgeries, that they get on and do it. They're very quick to go digitally. I hope they're not going to be too slow to resume some normality. Sorry, it was not a quick question, but that's it.
Again, I think I've probably got part of an answer. Obviously, much of the reason for going digital so quickly was around a spread of the infection and the like, and trying to lock down some of the risk of that, both for GPs themselves and for their patients. And much of the infection control guidance at this point still stands. However, in theory, at least, if a patient requires face-to-face care, they are still supposed to be able to access it. And that doesn't sound like the experience that you're describing to me. So probably offline from here, it might be worth just getting the specific details of the surgery that's got that message on there, and we can have a look at that. In terms of going back to normal, effectively, again, this discussion we haven't had, it hasn't really felt like normal for a while yet. Certainly there won't be any block on GPs going back to delivering care as they used to, but I think there will be an intent around maximising digital ways into practice. In theory, of course, that's meant to create more face-to-face capacity, because we're not bringing in people who don't need a face-to-face appointment. So the theory makes sense, but in this case, it doesn't sound like the practice of that theory has had the right result. I also similarly know of lots of people who actually have quite liked being able to access care remotely. It means they can go to work like normal, and do their appointments and carry on with their job. But it's part of the earlier comment, I think, from one of you guys around. We need to make sure the standard of general practice is consistent across the city, and it's certainly not acceptable just to be referred for a phone appointment and nothing else. There should still be face-to-face options available. And take under advice. I haven't got an answer in terms of whether people will be put off, but I can imagine if I phone a helpline and I haven't got an easy way of getting onto a call or to a digital consultation, would I then access care as I probably should have done? Possibly not. But we'll have a look. We'll have a look at the output of that survey as well. That was a national survey, I assume, David.
Yes, it was national. Yes.
Yeah. Thank you very much, David. Phil, thank you. Rose, thank you. We have run over time. We're very grateful for the time you've spent with us. I hope you found it useful, and we look forward to seeing you with us again. Thank you very much indeed.
Thank you, Stuart. Nice to meet everybody.
Thank you. Nice to see you.
Thank you both. Time is now running away with us a little bit. We've got half an hour of our scheduled time left. Ruth, if we can move on as quickly as we can through the rest of the agenda without doing it injustice. Healthwatch activity, Ruth, please.
Okay, so this is the usual report on the things that we've been doing. So the first section relates to the work priorities. So that's a summary of some of the work that we have done. We still have a piece of work ongoing with the Carers Trust around the case studies. So we hope that we'll be able to have some information that we can put together from that. Just a few highlights really from the information. So this meeting is not at the end of a quarter, so you haven't got the full quarter stats or anything because they would be pulled off in April. But just a note on how the website sessions on the Healthwatch website have increased. So this is figures just for January and February. So our new website went live just before Christmas. So that looks to me like a very successful outcome from having a new website, because we had 3,000 website impressions just in January and February, as opposed to 2,146 for the whole previous 3-month quarter. So that's quite a change. So we are going to hopefully be doing some more analytics for the website so that we can actually see which pages people are visiting. So as I said, we've got a section on COVID vaccination at the moment, and we are pulling off quite a lot of inquiries into our information service related to COVID vaccination. And when I ran the stats for that, which was a little while ago now, 47% of our contacts, either by phone, email or web form to our information service, were in relation to COVID vaccination in one way or another. So there's quite a big information need out there in the population. So we're not the only organisation that's putting out information. There's information on the CCG's website, there's information on CWPT's website, but what we've been trying to do is to make it as simple as we can for people and to respond to some of the queries that people have been getting. So just one question for you in that I had a contact from Coventry and Warwickshire Partnership Trust last week asking if you would like to organise a meeting with them. It would be an online meeting to talk about the outcomes from their quality goals for the last year and to have a conversation about what their quality goals going forward are going to be. So sounds like a sensible idea to have that opportunity to touch in with the trust, but it's kind of up to you. So is that something that you would like to do? Nods. Nods and thumbs up. Okay, so I'll go back to them and say that we'll do that. It also looks like this might be the final year of quality accounts. So as the system is changing, I think the requirement for NHS trusts to produce a quality document with specific quality goals in it will shift in some way. However, there is good practice in this process in terms of engaging with patients, service users, looking at what you know about the quality of your services and identifying the things that you need to work on, and then how you're going to know if you've achieved them, which hopefully should stay in one form or another. So that's everything on that paper. Anybody got any questions on the activity update paper?
Any questions on paper one for Ruth? Are we all happy on that? Good. In which case, paper 2, please.
Paper 2 is the reps report. So over to any of the people who've been to any meetings, if they want to say anything. I think because everything is quite fast paced at the moment. A lot of the topics in meetings are related to COVID in one way or another. It feels like information changes quite quickly. So whatever is written will not be the up-to-date picture. But I don't know if there's anything that you wanted to pick up, David, from the adult social care stakeholders group.
No, I don't think there's anything else. There's another meeting coming up next month.
Okay, so there's some interesting information in that report from you, David. So I recommend everybody has a look at that. So they are also working on the digital technology front. So it's not just NHS services and digital technology. There's been a change within social care as well, which is something that we need to be aware of.
Sonia, you posted a message a moment ago. Did you just want to amplify what you were saying?
Try and do that. Sorry, I was just letting Ruth know that I was going to chase up those case studies for the carers.
Oh, that would be really helpful. Thank you.
I know the team have been working on it, but
well, Felicity has a meeting this morning with your worker, Michael, I think it is, isn't it? So
I'm going. After this meeting, I've got a meeting with Mike anyway, so I'll chase.
Oh, right. Okay. Yeah. All right. Fabulous.
Can I just add, without wanting to sort of throw a bomb in the water, as it were, just on the digital issue, and it's not just the digital issue, but more and more at meetings I've been attending of late, people from the NHS, and I have to say, and also some aspects of the Healthwatch network have been saying, and I summarise to a large degree here, returning to how we were pre-pandemic is not an option. Now, you make of that what you will, but people are not inclined to ditch what they believe are advantages that may have been gained through going digital and so on. Not just the digital issues, but that's obviously clearly a fundamental part of it. That's just something to bear in mind as we.
I'm very conscious of that too, Stuart, and I think there does need to be some reasonable pushback against that.
Okay, thank you. We move on.
What actually needs to be understood is what the outcomes are. For people, and I know that you've been articulating that very eloquently in different meetings as well, because it's not actually fully understood what the knock-on impact is going to be at the moment for people, is it? Because people in the population have been behaving in unusual ways as well, or have been told to do things very differently. So, it needs to be fully understood. And that's why Healthwatch England is actually calling for NHS England to do a national inquiry into access to GP appointments. So it was a topic that was quite high up the agenda in Healthwatch prior to the pandemic, but now it seems like it's starting to become clearer what the variation in people's experiences in terms of being able to get to speak to somebody in the right way.
Sure. Stephen, did you want to just chip in there?
I think, I mean, I think we're just looking at sort of a blended model going forward. Certainly from a personal point of view, I would not go to my GPs because I wouldn't want to go and sit in a waiting room for an hour when I'm supposed to be at work. Whereas since, a number of years ago, they introduced telephone consultations, I probably had more contact with them. We do need to think about blended models. It has to be what works best for the patient. In whatever service it is, and I think that's one thing we've learned from this. I don't think saying we're not going back to the old way. We're not, but we're going somewhere in the middle that suits.
It has to be somewhere better, doesn't it? Really, something at least effective.
That's the point. It has to, whatever we go to has to be better than we've had. But I think the point that David made in his anecdotal story is actually quite critical in many ways, because I am absolutely convinced that there are some GPs, for example, not all, but some, who are determined now that their way is the way, and their way is probably going to be telephone calls first and foremost, and we'll only see if we really have to. I'm sorry to put it as bluntly as that, but that is really where a lot of them, some of them, to be fair, are going David, you wanted to say something?
Yeah, just following up what Stephen and you just said. I may be getting labelled as a digital doommonger, but I'm not. I think what Stephen said applies to many people. That telephone or digital is the answer for many of the previous long sitting around in doctors' surgeries. You know, I think that's very good. But you know, to follow up what you just said, Stuart, I don't think we should allow GPs to consider it the norm, because I think some will if we're not careful.
Yeah, I mean, the case they make, of course, is they can get through X number more consultations per day by doing it that way. It's much more efficient and so on. But actually, it's also an easy cop-out for a lot of them. Again, that's being very blunt and unpleasant about it, but it is. And it's something we do need, as Bruce said, to push back on where it's relevant. Ed?
And they're doing a lot of these digital calls from home as well.
Well, probably. Ed, what did you want to say?
Just when they first introduced kind of providers that exclusively delivered digital consultation, they tended to cream off all the easy cases for GPs, and all the difficult cases were left with GP practices that weren't using online methods. And there's a danger of that there being two tiers of service, where some practices, their quality is affected because they're not embracing these models. So that's something to monitor, I think, and Healthwatch can have a role in that.
That's very good. Thank you.
So just a final observation whilst we're on the RETS report as well is I saw yesterday that there has been correspondence that's gone out from a national level to local authorities to say that they need to restart face-to-face meetings, which would be after the 7th of May. So alternative arrangements have been in place for things like scrutiny, health and wellbeing board due to the pandemic. But to extend the change that has been made would require some more primary legislation, and that is not being pursued. So that correspondence has gone out across the country.
Okay, thank you. Let's move on then, shall we, to item 7, service updates.
Okay, so the remaining items on the agenda are for your information. So a slightly mixed bag of pieces of information. So the first section is about things to do with services that might impact on local people. So we keep a track on changes to pharmacy services, and there have been more over the recent couple of years. So we've had a change of ownership come in this month, which is around the pharmacy, which is on Bennett's Road North in Kersley. So it's a change of ownership. So I don't know. It hasn't been made clear by NHS England if that will affect the services that are available at that pharmacy, but the pharmacy is still going to be operational. So some other bits of information that went out in your paper. So there's a key worker pilot, which is around supporting children and young people with autism and or learning disability. There's also some information about long COVID services. So Circle Rehabilitation Hospital. UHCW also has a long COVID service that it is developing as well. And finally, I'm flagging up, it is a national publication, but it has local implications. So these are the latest guidance, the operating model for hospital discharge. So hospital discharge is one of the areas which has gone into the kind of national command in terms of the approach during the COVID period, and that is one of the areas where there is a lot of consideration of how things are working better, and that changes should be maintained. So hospital discharge has effectively been sped up, and there's a model which is similar in some ways to the discharge to assess model that we had locally, but also changed in some ways, which is the model of getting people out of hospital and then assessing them for any ongoing care needs, either in a short-term bedded facility, or when people are back in their home with extra support.
Ruth, could I just ask what's the location of the Circle Rehabilitation Hospital?
I don't know if it doesn't say in the paper. So is that a key bit of information that's missing, is it? I'll try and find out.
Just as Anthony Street, the West Midlands mayor, was talking about it, but no, it doesn't say where it is.
Okay, Birmingham, maybe. I don't know. I'm just guessing.
Okay, thanks.
Okay, we're on to item 8 then, I think, Ruth, the Healthwatch England update.
Yes, so again, for your interest, so this is Healthwatch England coming back with the results of work that they have done. And of course, Healthwatch England's work always builds on the work of local Healthwatch, because local Healthwatch identified the issues and the concerns of people in different areas of the country. So in their relationship with NHS England and the Department of Health, there's an annual appraisal letter. So you can see within this that various things are being acknowledged as being, at least in part, a result of Healthwatch England or Healthwatch activity. And I haven't had a chance to digest it yesterday, but I saw something come in about dentistry, which we'll send on to you as well. So Healthwatch England are still working at a national level around the challenges around access to NHS dentistry, which areas of the country are experiencing, because it's actually it's a contracting issue. It's about how contracts are constructed and how payments are made, and that's why some areas of the country have ended up with very little or no NHS dentistry provision. So that if you speak to Healthwatch Warwickshire, they'll say that there is no NHS dentistry in Rugby, for example. We do have some NHS dentistry in Coventry, so our position is not as bad as some areas of the country, but that doesn't mean to say that there aren't challenges here too.
Thank you. Anything further for anyone on that? No, everybody happy? In which case we'll go on to item 9, which are publications for us all to be aware of, really.
Yeah, so some links here to some things that have been published. So you may have seen in the news a little while ago that the CQC was looking at do not attempt cardiopulmonary resuscitation decisions in the light of COVID-19. It seemed that practice was patchy and bad in some areas, and that some groups of people had almost been placed under blanket do not resuscitate orders on the basis of their age, or in some instances that were given in the news reports, it was about people with learning disability. So some significant issues flagged up by the CQC there, so it's worth dipping into that report. And obviously people not being involved in the conversations around decisions around do not attempt resuscitation, which is obviously people should be. that is what is supposed to happen, and that there can also be instances where a do not resuscitate order has been placed on somebody's notes and then people have recovered, but it kind of keeps following them into different care settings as well, which is also inappropriate.
I think so. One of the concerns from that paper is many of the anecdotal reports, which the paper actually does rely on quite a bit as part of the evidence it's considered from the CQC, is that it's not just the CPR resuscitation attempts; it's other means of treatment have been denied as well to people when under the general heading of resuscitation.
Yeah.
And it is true, of course, that CPR, particularly perhaps in an older person, can do more harm than good if you do it right. I mean, there's one quote, the famous quote, I guess, from within the practice that operates CPR is that, if you're not breaking ribs, you're not doing it right. Well, obviously, with elderly people, that's not a very pleasant state of affairs to find yourself in, and that there's far more to it, as I say, than just CPR. And I just hope that this report, which obviously focuses on DNA CPR because that's the terminology within the system, I hope it just doesn't end there. I do hope it continues and investigates it further.
Yes, yeah, there definitely does need to be some action taken by organisations to make sure that there is good practice really in place. So that the next document linked to is its guidance from NHS England for NHS trusts on communicating with patients. So this is of interest because sometimes communication with patients kind of falls down a bit, doesn't it, really? So some of the things that we flagged up in our report that we just published really were about communication and communication in the light of the changed routes of reaching services because of COVID, but also, you know, you could argue, is enough thought put into how you communicate with the people who are using services. Then there's a Public Health England report, inequalities in oral health. So this again links in with the agenda around dentistry, but coming at it from a slightly different angle. So one of the factors that is really important around people having access to dentistry is that dentistry provides a route for picking up other issues, one of which is oral cancer, which if it's picked up early on is treatable, very treatable. So other things might be being missed if people don't have access to dentistry. And then you've got the latest CQC's COVID Insight report, which is around the issues and things that they are picking up. So a mixed bag of exciting reading.
Always worth spending some time before you go to sleep at night studying some of those. Good. Any questions? Any other business from anybody? Yes, Ed, please.
Just at the moment, I'm working for UK Parliament, and I'm looking to publish a briefing in 2 weeks' time on childhood obesity. And Parliament's function's kind of similar to Healthwatch's in that it considers different bodies of evidence. It has a fairly balanced, it aims to have a balanced perspective and scrutinises policy. And recently, there's been the National Institute of Health Protection and all the announcements surrounding that and how obesity is going to be a focus. In something called the National Child Measurement Programme, Coventry is seen to have a problem with obesity. Coventry is a marmot city. Obesity is closely related to healthcare inequalities. So I was just wondering if that would be of interest to the steering group, whether I could just send it on for consideration or do a mini presentation. It basically covers the effect of environment, obesity stigma, service planning and gaps and satisfaction too.
When is that due for publication in?
2 weeks' time. Okay. It's out for review at the moment, so depends how.
Can we send it round in the first instance? Would that be okay for people? So yes, if you send it to me, Ed, then I'll make sure that everybody gets it. And I think it's important, isn't it, to kind of recognise the connectivity between some of these issues, really. So Phil was kind of alluding to this earlier when he was speaking, wasn't he, in terms of trying to refocus so that you're trying to enable people to be more well rather than patching them up when they're ill for various reasons, which is what the NHS kind of does, isn't it?
And when things touch on health inequalities, I think it's
and health inequalities. Well, we know that there are big health inequalities in the population in Coventry, and yes, on markers like childhood obesity, we don't do well, but it's very interconnected, isn't it, in terms of all of the life experience and issues that people experience that are the wider determinants of health. And obesity, of course, is going to go up the agenda nationally because it's a morbidity factor for COVID, isn't it? So.
Yeah, so it would only be 4 pages long, and it would give you an oversight of what MPs and peers are looking at the moment, and it would be in plain language. It would be
fabulous. That sounds like our kind of paper, Ed.
Plain language is always welcome. Thank
Excellent.
you very much. Very good. Anyone else? Any other business anybody else would like to raise with us? Yes, Christine, please.
Thank you. Sort of similar vein actually to what Ed's saying. There's a report that's been published by the Women's Health Committee, and it's looking at the impact of COVID on women, but it's very much looking at the economic impact. So it might not be something that sits, as a core element of Healthwatch, but I'm happy to share the report with you all because it does link into social determinants of health, and there's a lot of information in there. It's an impact report, so there's lots of statistical information which voluntary sector partners may want to look at in terms of funding. So there's a lot of data in there. So if you're happy, I can send the report out to you all. It's quite a meaty read, and there's not much consultation with the women's sector with the report. But there's useful information in there. So if you're happy, I can send them out.
Thank you.
Again, if you can't sleep at night.
Has it got a summary as well, Christine?
There's a lovely little exec summary that just tells you all you need to know.
All right, fabulous.
And anybody else? No? Good. Thank you very much indeed. In which case, the next meeting is my wife's birthday, the 1st of June. Hopefully we'll finish on time, otherwise I'll be in trouble. But thank you very much indeed. We'll see you again. And thank you for those of you that have been following us on YouTube. If you've found it interesting, I hope you have. Thank you all. We'll see you next time. Thank you.
Many thanks. Bye-bye.
Goodbye, everybody.
Bye.
Bye.